Good morning, and thank you for an opportunity to address you today. When I was first asked to give this talk, I thought, oh, that'll be easy, identifying low-risk pregnancies. I have no disclosures. I think it's important to note that the decline in maternal and neonatal mortality are perhaps two of the 10 great public health achievements since the 1900s. And there have been many technical and political changes that led to this decline, starting back in 1933 when they convened the first maternal and child health reviews, on through what many believe is the advent of moving more births into the hospitals, the use of antibiotics, transfusions, as well. It brought the maternal mortality rate down to about 7 per 100,000 in 1982. However, more recently, there's very clear evidence that the maternal mortality rate is increasing. You can see in blue the rate in in green the rate in the United States is about 13 per 100,000, and this data actually comes from the California Maternal Quality Review Committee, where it's about 16 per 1,000 per 100,000. So what is low risk? And just to sort of orient how I got here to answer this question, I tried to limit it to Medline 1996 using current English language. These are the cross terms that I used that included both low risk and pregnancy, risk assessment and pregnancy, levels of care in pregnancy, and all of these terms were cross-referenced with midwives, family practice, birth centers, and home births. And I did ultimately end up limiting it to developed countries, although there's a lot of very interesting things going on internationally. And then somewhere in the midst of this, we had a conference call, so I got a second task, and that was to also think about low risk and the concept of maternal transfers. So the earlier discussion, or panel discussion, was a great segue for some of the things that I'll discuss today. And I also wanted to make sure that I included making sure that I was aware of the consensus statements by many of the representative organizations, and so they will be also referenced here today. So when we first asked the question, what is low risk, I just want to start with the sort of, I thought, interesting quote by Warren Buffett, which says that risk comes from not knowing what you are doing. So the history of risk assessment probably starts, or at least the closest that I could find is 1929 from Dr. Janet Campbell in the United Kingdom, where she implies that the first requirement of a maternity service is effective supervision of the health of the woman during pregnancy. And thereafter, the UK Ministry of Health set the antepartum exams to begin at 16 weeks, have another one at 24 and 28 weeks, and then monthly to 36 weeks and weekly thereafter. It was advised that they check the height, the fetal heart tones, and test the urine, and that week 32 and 36 should be by a medical officer. And this should look actually somewhat familiar because it's not much different than what we're still doing today. However, we have added screening interventions to identify high risk. So Mead defined a standard primip eligible for midwifery care in the United Kingdom as being Caucasian, 20 to 34 years old, a height greater than 155 centimeters, singleton, vertex, greater than 37 weeks, delivered as planned in the site that they planned, or as they call it, booked, with no medical complications. However, in the United States, it's obviously a little more complicated. So when we ask the question low risk, I ended up having to say, well, low risk or at risk for what? And most of the models actually talk about risk assessment for preterm birth, or for predicting perinatal morbidity and mortality, or predicting cesarean delivery, or VBAC, or uterine rupture. There was no risk assessment tool that specifically addresses the risk of maternal morbidity or mortality. So then I took a teleological approach and I said, okay, well, given that home births or birth centers are supposed to be low risk, what are the criteria for that? And so candidates for home birth says that the exam and lab tests must be within normal limits, which defined as no evidence of the following. And these are all conditions that probably make sense to most of us: chronic hypertension, seizure disorders, HIV positive, severe psychiatric disease, persistent anemia, diabetes, heart disease, kidney disease, endocrine, I mean, pretty much any disease, right? Multiple gestation and substance abuse. Candidates for a birth center, this is published by the American Public Health Association in 1982, and they have a manual that says the center should specify criteria by which risk of status should be established, and the medical and social risk factors which exclude women from the low-risk interpartum group should be clearly delineated and annually reviewed. So now we get a little fudge factor in here, right? And they reference actually some older papers, but they conclude that really what you're trying to do is to determine sick from well. And again, all these models were focused on predicting perinatal mortality rate and not maternal risk. But they did emphasize that risk should be continually evaluated in the prenatal period, the interpartum period, and postpartum. And they ultimately went on to specify specific high-risk conditions, which, when you went back to the older literature, included things like recurrent miscarriage, history of stillbirth, history of preterm birth, and then the conditions that I talked about earlier. Things that got added in, however, are thyroid disease and macrosomic infant. So if you think the baby's big, perhaps it's not a candidate for birth center. And this was the first time that they actually put in some sexually transmitted diseases as well as drug and alcohol use. And then just to sort of reflect that it's a sign of the times, this is from Aubrey and Nesbitt, who actually mentioned TB as being a contraindication. Uterine anomalies, which now that we're doing ultrasounds, they were becoming more apparent, and bacteriuria. So probably the most, if we bring it up to current times, the most common reference is that from Guidelines for Perinatal Care, which is a joint document by the ACOG and AAP, which argues that perinatal care should be integrated into a system of geographic regions that provide timely access to care at the appropriate level for the entire population. And there are two goals, the first of which is early and ongoing risk assessment, and the second is to improve referral and consultation among institutions that provide different levels of care. They again specify specific conditions that we've seen pretty much already, so I won't go over them again, except to say that a new one now is DVT and PE and chronic anticoagulation. But pretty much the others you've probably seen already, as well as the family history of genetic disorder, which now that we're screening for these things, again, this is additional information. So it does show that as we learn more, the number of conditions that get put into this category starts to increase exponentially. So in summary, what is low risk? Well, it's the opposite of high risk, right? And to paraphrase the Supreme Court Justice, Justice Stewart, I have no criticism with the literature. When faced with the task of trying to define what may be undefinable, I shall not today attempt further, but I can tell you in the face of it, I would know low risk if I saw it. So then I move to the task of, given low risk, what happens to you? And that depends on where you deliver and who takes care of you. Villar et al., in evaluating patterns of prenatal care, found that there was no difference between midwife, general practice care, and OB care with reference to your risk to cesarean, anemia, urinary tract infection, or postpartum hemorrhage. They found a trend toward lower preterm birth and antepartum hemorrhage and perinatal mortality rate when care was provided by a midwife or general practitioner. And they found a significant decrease in PIH eclampsia with midwife and GP care, and a significant increase in failure to diagnose malpresentation with midwife and GP care. And essentially, the satisfaction was the same or higher with midwife or GP care. There's been studies that have shown there's wider variation in care in healthy women, but more consistent care with complicated deliveries, and that, in fact, care is dictated by the structure, process, and culture upon which you receive your care. There's evidence that for low-risk women, midwife-led care do better in freestanding or integrated birth centers where midwives have autonomy, and they practice in a small-scale setting. Midwives in integrated centers tend to incorporate the risk culture of the environment, such that units with high intervention rates, midwives perceive interpartum risk to be higher. They underestimate the progress or likelihood to progress normally, and are more likely to risk out a patient compared to midwives working in units with low intervention rates. Based on systematic reviews, approximately 20% of laboring women are transferred out of midwifery care. And there's a Canadian study that reported on interpartum transfer rate in hospitals that did not do C-sections, and they found that it was somewhere between 9.5 and 12%. And timing is everything. This paper was recently published in the last month, and it's very well timed. I thank you for that. And this is looking at birth center outcomes in single-term vertex with no medical or obstetrical risk factors precluding a normal vaginal birth or requiring interventions such as continuous electronic fetal monitoring or induction of labor. They started off with 22,000 records, and 18,000 were ultimately accepted for birth center care past the first trimester. And in this population, 13.7% were referred to a physician for medical or obstetrical complications, primarily due to post-dates, malpresentation, PIH, or non-reassuring fetal heart rate tracing. And 15,000 were planned eligible for birth center care. And what they found ultimately is that the fetal and neonatal mortality rate was consistent with those of birth from low-risk women reported elsewhere in previous settings, including hospital births. And again, segue from earlier, someone wanted to see the flow-through, and this is the most recent data of what happens if you plan to deliver at a birth center in the United States of America. And what's really important is, if you follow the graph, is that when you get to the 18,000, which is about midway through, okay, there's about 13% that get transferred antenatally. And so if you actually walk into the door, once you get admitted, there's another 5% who get transferred even before, and that's due to like ruptured membranes, not in labor. And so they're left with 14,000 women, and another 12% get transferred intrapartumly. And those diagnoses include arrest, non-reassuring fetal heart rate tracing, diagnosis of breech, bleeding, pregnancy-induced hypertension, cord prolapse, and seizure. But what's even more important that I thought about that is that less than 1% of those are emergency transfers. So the transfer comes up, but they have plenty of time to make arrangements to get the women where they want to be. And the other thing that I think is interesting is we keep talking about nullips being so low risk, but 82% of those transfers are for our nullip risk women. And then another 2% are transferred postpartum, and that's primarily due to postpartum hypertension or postpartum hemorrhage. And again, only less than 0.5, so less than 0.5% of those are considered emergency transfers, again, alluding to the fact that there's time to get these women to appropriate levels of care. So now I have to ask, is there any other information to guide us? And there's a study that came out looking at maternal transfer for critical care from freestanding birth units. And this is looking at a 24-year period, pretty concurrent times, 1982 to 2005, and found that there were 117 transfers out of 122,000 deliveries, which is approximately 1 per 1,000. 79% of these women were transferred for ICU care, and 20% were for medical or surgical care that's not available at the OB unit. 13% were antepartum transfers, and 86% were postpartum transfers. And again, hemorrhage and hypertension accounted for 56% of indications for transfer. So these are starting to be sort of recurrent themes here. The deaths were pretty low at 4.1 per 100,000. And that's sort of interesting to keep in light of mind when we think about nationally it's 16 per 100,000. And the death to transfer rate was 1 in 23. And that implies that these women who got transferred were actually pretty sick. So another question, and this is actually sort of borrowed from Dr. Minkoff when he was addressing the immediately available standard with regard to VBACs in any setting, particularly hospitals. And he asked, are there other obstetrical emergencies that could similarly benefit from the immediately available standard, or that should be subject to the same standard? And it raises the notion that the guidelines or data that suggest 30-minute rule may not be good enough if we're looking specifically at fetal compromise, which is usually time dependent. And in that light, it actually does come to bear that there might be specific conditions to think about, such as placenta previa or accreta, abruption, cord prolapse, uterine rupture, and that in these settings we should be thinking about golden minutes comparable to the golden hours of stroke, a myocardial infarction, or sepsis, all of which are things that you can't predict, right? And then Dr. LaGrue makes the comment that most emergent cesarean deliveries develop during labor in low-risk women and cannot be anticipated by pre-labor factors. So in conclusion, low risk is a singleton term vertex, no other medical surgical conditions, but it can also be defined regionally or locally, especially as it relates to collaborative models of care. It's a dynamic condition and subject to change, and we should always be thinking about it, or at least as a physician model, in the antepartum, intrapartum, and postpartum periods. And it's important to remember for everybody that the change can be acute and unexpected, and that the overall absolute rates are low regarding adverse maternal and neonatal outcomes, but they should be triaged appropriately with skilled clinicians. When you recognize that 39% of deliveries occur in hospitals with less than 500 deliveries per year, or approximately 2 deliveries per day, it becomes clear that all hospitals cannot provide the same standard of care. And while there are known relationships with hospital volume and outcome, such that more volume is usually associated with better outcomes, this is counterintuitive to data regarding midwifery-led care, where small scale appears to be associated with better outcomes. So we have to ask ourselves what can be learned here. I think it's important to ponder that risk-appropriate care should be evaluated in the context of both high risk and low risk, and that high-risk women and/or conditions need to be cared for in appropriate facilities with appropriate resources, and that we need more data regarding conditions most appropriate for higher level care, and that needs to be separate and distinct from our conversations about alternate birth sites, and specifically ask ourselves what maternal conditions require delivery at level 3 or level 4 sites. And then finally, low-risk women may also need to be cared for in appropriate facilities with appropriate resources, keeping in mind that increased adverse events occur if low-risk women are cared for in high-risk, high-intervention sites. And then finally, if we want to impact ultimately on maternal mortality, we might want to think about primary prevention, and the cartoon says, see what kissing can lead to.
Our next speaker is Dr. Betsy Armstrong, who's an associate professor in the Department of Sociology with joint affiliation in the Woodrow Wilson School and the Office of Population Research at Princeton University. And the title of her presentation is A Sociological Perspective on Risk Assessment in Pregnancy.